Some main things we're going to be focusing on tonight. So understanding nutritional needs, a bit about micronutrients for specific populations, warning signs, and maybe some common red flags or things to watch out for to potentially refer your patients to a dietitian. Insights into nutrition across various life stages, and we're going to keep things quite practical tonight and really show you what it is that we do or what we might do with our patients in a typical consultation, because often people don't know what's actually involved in a dietitian consultation. To begin with, we're going to just go over our main macronutrients that contribute to dietary energy. So firstly, fats, which are composed of glycerol and fatty acids. We aim to get about 20 to 35% of energy from fat. Fat helps with the absorption of different vitamins, A, D, E, and K, our fat-soluble vitamins. We've got our good and bad fats, so our saturated fats, which are our not so good fats, and then we have our poly and monounsaturated fats, which are the ones that are the good ones. So saturated fats will be in things such as the fat in meat and things like butter and cream. And then our poly and monounsaturated fats are in things like our oily fish and avocado, nuts and seeds. Protein. So protein is made up of amino acids, and we aim to get about 15 to 25% of our energy from protein. Protein requirements really differ depending on age, life stage, whether somebody is ill or has a chronic condition, but generally we'll aim for about 0.8 to 1 gram per kilo per day for adults. And for patients with obesity, we tend to use an equation of 1 gram per kilo of adjusted ideal body weight per day. And protein we find in things such as meat, fish, eggs, nuts, legumes, and dairy. Carbohydrates. So carbohydrates broken down into glucose, which we use for energy. And depending on which guidelines you look at, we're looking at between 45 to 65% of our energy coming from carbohydrate. And we use this directly for energy. Our brain uses glucose and carbohydrates for energy. And we find them in foods such as bread, rice, pasta, potato, fruit, and dairy. And then energy. It's not a macronutrient, but all of our macronutrients have energy. So we're looking at kilojoules and calories. So if you're looking at how to work it out, so 4.2 kilojoules to 1 calorie. Our micronutrients, we're just going through some of these here, and then we're going to go through a few more a bit later. But vitamin A is a fat-soluble vitamin, which is involved in and important for our vision and immune function. So in terms of disease prevention, studies have shown relationship between beta-carotene and cancer risk reduction. Vitamin C, which is an antioxidant, which protects against oxidative damage and assists in the absorption of iron and copper. Vitamin E, also an antioxidant. The best evidence we have is for reduction in cardiovascular disease risk. Selenium, which is important for thyroid metabolism and also immune function. Possible reduction in cancer and coronary heart disease risk. Folate, as most of you probably know, prevention of those neural tube defects in the fetus and reduction in chronic disease risk. Calcium and vitamin D, really important for the bones and preventing those chronic illness such as osteoporosis and reducing fracture risk, especially as we age. And Lauren's going to be talking about that a bit more later. Sodium is important for maintaining our fluid balance. However, excess sodium can be an issue for blood pressure and leading to hypertension potentially. So we just want to watch that. We do need some though. And fiber is a really important nutrient, but it's made from the non-digestible parts of plant cell walls and really important for the functioning of the gut. And there is a lot of good research coming out where it's showing lower rates of obesity, cardiovascular disease, diabetes, and some cancers with high fibre intakes. And in terms of requirements for fibre, we're looking at about 38 grams a day for men and about 28 grams a day for women. So to start, I've just got a couple of quiz questions. So feel free to pop your answers in the chat. And if you just say, so first question, to guess how much protein is in 100 grams of beef. So we're looking at about palm size for that. And then how much protein is in 1 cup of milk. So feel free to pop a little answer in the chat, and then we'll have a look at the answers in a minute. And if you want to just say, whether you're saying beef or milk, and then your answer, and then we'll keep an eye out for the chat. If you feel comfortable. Hopefully the chat is working. It's working? Okay, that's good.
Oh, I think people started typing in Q&A. So
oh, yeah, in the Q&A. Oh, yes.
25
yep.
grams in beef and 10 in milk.
Mm-hmm.
And some people are not able to get the chat.
Oh, the chat. Okay. Oh, well, feel free to put it in the Q&A if that's easier. That's totally fine.
The chat is working. I just checked.
Mm-hmm. We've got 50 grams. So we'll have a look at the answer. Or answers. Oh, we've got one more. Quarter palm. Should we have a look at the answer then? So there's a range. So for beef, so per 100 grams, we're looking at roughly 22 grams of protein per 100 grams. But I would accept between about 22 to 28 grams, depending on where you look. So I think we've got one good answer there, 25. And then the milk, so about 8 grams of protein per 1 cup or 250 ml. So pretty close there. Yep. And then we've got 26 grams of protein, somebody else's answer, and 8 grams of milk. Perfect. All right. Let's move on. Thank you so much for that. And just a little note about protein. So an average protein requirement for a 51 to 70-year-old male is about 64 grams a day. So today we're going to be discussing a number of different topics. So firstly, pregnancy, then we're going to go into infancy, childhood and adolescence. Pregnancy, infancy and childhood, they're not our specialty, so we're going to be focusing a bit more of our time on adulthood and older adults. However, we're still going to touch on the basics of those first topics. And I'm going to hand to Lauren now, who's going to start with pregnancy and infancy, and then I'll hop back on shortly.
Thanks, Kathleen. I'm hoping everyone can hear me and see my screen well. Just quickly pop this one up. Is everyone able to see if I do that? Is that looking all right, Kathleen?
Yep, I can see that, Lauren.
Cool. Hoping that's all good.
That looks great.
Excellent. Perfect. Yeah. Hi, I'm Lauren. What was that? Oh, okay. Hi, I'm Lauren. I'm very happy to be here tonight with you all. So I'll just take you guys through, I guess, the first part of the life cycle at this point. So looking into pregnancy. Like Kathleen was mentioning, we mainly would see children from age 10 above, and we don't see them too often. So we won't go too far into infancy. Kathleen will touch a little bit on childhood, but we certainly can see like pregnant women here and there. So we know a little bit more about that area and can discuss it in a little bit more detail. And I guess it's really the start of the life cycle. So the nutrition for that point is quite important. Um, so what I'm going to be talking about, at least to start off with, is healthy weight gain during pregnancy, meeting general nutrition requirements. So typically what that might look like if someone did come to see us in private practice would be making sure that they're hitting their everyday nutrition targets for the serves of the main 5 food groups. So looking at the breads and cereals, looking at the fruits and the vegetables, meat and vegetarian or vegan protein sources, and dairy products to ensure that they're supporting their own body through pregnancy and also their growing baby as well. So having a look at healthy weight gain to begin with. So we base this depending on what the woman starts off as. So if someone starts at an underweight BMI, we'd encourage that little bit higher amount of weight gain per week, because we know it's pretty healthy for them to be gaining at least significant gain. And we want to make sure that they're supported to do this in a very healthy sort of manner whilst meeting the nutrition needs that they require as well. When someone's at a healthy weight, so a pretty typical, maybe typical sort of pregnancy, we'd expect to see 0.4 kilos per week. And that's something we'd address and with them depending on what point of their pregnancy that we're seeing them at. So if they're at their second or third trimester, which is where we might typically come across this patient, we can count back the weeks and think, oh, okay, has this been a healthy sort of typical pattern? Has the weight gain been a bit rapid for whatever reason, or are they not quite meeting those milestones? So we can work with them to make sure that that's all going ahead in the correct way. The weight gain is still encouraged if someone starts at an overweight or obese starting point with their BMI. However, we want that to be a bit slower and a bit less overall compared to someone starting in an underweight or healthy weight range. And that's something we can figure out by looking into their diet and seeing if there's any dietary parameters that are contributing towards that. So it just mentions at the bottom as well, this is something from Women's and Children's Health Network. In the first trimester, the weight gain is very small, and the most will happen in those second and third trimester. So that's where we would likely be working with these clients. Next, we'll look at what we would do to encourage this healthy weight gain. So we don't really do anything extra in the first trimester. It's just sort of adjusting to the pregnancy, probably helping them through a bit of morning sickness and helping them get through that and eat enough, because that can be the trickiest part. By the second and third trimester, that's not as much of our concern. It's more just making sure they're eating enough to support the baby. So I've put these in a few different measurements of energy. So the guidelines mention that during the second trimester, a woman should be having an additional 1.4 megajoules a day. But depending on how you work, so at AEP, we work in both kilojoules and calories, depending on the client. So it's about 1,400 kilojoules extra a day, which sounds like a lot, but that's only 330 calories, which could easily sort of creep up over your day pretty naturally. So we generally wouldn't have to make too much effort to get that extra amount of calories. And then third trimester, it's a little bit more, so about 450 calories a day to gain that healthy weight. Now, the nutrients of interest we're just going to be touching on. So during the especially like all trimesters of pregnancy, but in particular those last ones, we need to make sure that the mother is getting enough of these nutrients in particular. So iodine helps with the development of the baby's brain. Getting enough of this through general foods typically. So it's found primarily in things like table salt. It's also fortified in a lot of different products that we eat every day. So a lot of your typical cereals like cornflakes, Wheat Bix, and then different breads like Tip Top, Wonder White, all of those classic things that families would buy are pretty rich in iodine, and that's usually preventative. So even if someone didn't know they were pregnant, they would typically be getting enough iodine as well. It's relatively hard not to meet it, but if someone was really not eating enough, there's a chance that that would be low. Folic acid, which is protective against birth defects and neural tube deficiencies in the formation of those cells. So we know that that's a big thing with pregnancy, very important one. It's again fortified in a lot of those different foods, and it's hard to miss out on if we are eating those typical things. There are certain cases where we would be concerned about that and be needing to do even more additional supplementation. But most of the time, a pregnant woman will be put onto a folic acid supplement anyway. Iron, so that's going to be an important one. We can actually look at that from a nutrition perspective as well. We would see if the client is having enough of the iron-rich foods in their everyday eating, and then look at some additional supplementation if that's not the case, or if they are vegan, vegetarian, and require a little bit more to get them through. Protein is going to be a big one just for immune system function, blood supply, and tissue growth to support baby. That's going to be, again, something we would kind of count up and make sure that she's getting everything she needs during that process. B12 is one, again, if you're getting enough iron, you will typically be getting the B12 as they appear in a lot of the same kind of foods. However, we would have to have a look at that in the blood tests and see if that supplementation is required. Important for nerve and brain development. And then calcium will be another important one. And vitamin D ties in with this. So they're both important for the bone and teeth development for baby, but they're both important for mum as well, because the baby will, during growth, kind of take calcium from mum's bones if needed, and to support that growth, because it's the most essential process, which can leave mum sort of vulnerable to things like osteoporosis in the future, brittle bones, frailty. So that's how the whole life cycle kind of connects a little bit with each other. The vitamin D is related because it helps the calcium go from the blood to the bones and teeth, where it sort of sits and is stored. So those two are very important as well. And a lot of the time, vitamin D supplementation is needed for that reason. This is sort of just going on from that. A multivitamin like Elevate is recommended, and we can kind of count back. If we see a woman know that she's having Elevate, we kind of get an idea of how much of those essential nutrients she's getting, and we can kind of see through their food if they're sort of meeting up the rest through what they're eating. It's just a way to safeguard against any of those important nutrients, making sure there's no deficiencies. And then the vitamin D is another one typically that's supplemented as well. There's not many food sources of it. Cod liver oil is one, and that's not very appealing to most people. So we would say a supplement is a lot better. Lactation in infancy. So I won't touch too much on infancy in general, but lactation's an important one if we're supporting a woman post-pregnancy who is potentially just wanting to get back on track with health and fitness and also support her baby. So the lactation is, again, relates to that part of infancy because it's helpful for the brain development, cognition, and the immune system of the baby. It is said to have some long-term health benefits for later on in life, so it can reduce the risk of becoming overweight, obese, or developing some of those comorbidities, so type 2 diabetes, hypercholesterolemia, and hypertension. Breastfeeding is recommended until around 6 months old, and then continuing with supplementing different proper foods beyond the age of 12 months. The infant formula would be the best alternative if mum is not able to breastfeed. And then from 6 months of that, the baby should start to be offered different range of food. So a paediatric trained dietitian would take them through all of the different textures and types and milestones when it comes to that sort of thing, which is a quite complex area. The additional energy requirements during lactation, so around that 480 calories a day roughly. So a little bit, basically an extra meal a day roughly. We also need to remember that because breast milk is a fluid, we need to replace those fluids to make sure dehydration doesn't occur and to support the lactation in itself. So an additional 700 mils a day of water, so just over half a litre a day extra for this woman to support breastfeeding. Looking at food safety in pregnancy, so another big one relating to nutrition. So there is a fair bit more risk associated with different foodborne illnesses in pregnancy compared to the average Joe. So the immune system function is compressed a little bit during pregnancy, which leaves these women a bit more susceptible to things that different bacteria and different things, pathogens that might be on our everyday food potentially, that our immune system would fight off. We wouldn't necessarily get sick. But if they got it, it would turn into a foodborne illness, which can be quite harmful for mum and baby, compromising the pregnancy. So we have a bit of a list of foods to avoid. And what we might do if we saw this person in clinic is we'll look at their diet history, what they're normally eating, and think, is there any of these risky foods, or are they seeming a little bit unsure in that area? Because a lot of the women have a good idea. They will know what to avoid and they're very vigilant, very on it. Occasionally there will be things that slip through the cracks and we just want to make sure we're reducing any risk of harm. So biggest sort of things would be charcuterie board favourites, so soft cheeses, pâtés, that type of thing. We'd deli meats, all of those things would be out during the pregnancy. They can cause risk of listeria. Same thing with any sort of uncooked sort of fish, so raw fish, smoked salmon type of thing. Any of those type of foods would be avoided during the pregnancy to avoid listeria or listeriosis infection. We avoid anything raw, undercooked eggs, so poached eggs, runny sort of boiled eggs as well. With soldiers, we would say probably not in case of salmonella poisoning, and it does go without saying no raw chicken or anything like that, which no one should be eating anyway, but just in case. In general, we have mentioned the raw and undercooked meats, so like rare steaks as well. We want it to be very well cooked to a particular temperature. That can cause something called toxoplasmosis infection, which is quite dangerous for the baby. We avoid alcohol, of course, to avoid fetal alcohol syndrome. We limit caffeine to avoid any damage to the baby's growth, so about 1 to 2 cups of coffee a day or 4 cups of black tea. But you can drink a fair bit more of herbal tea because it's more hydrating, lower caffeine content. Then the other big important one is mercury poisoning. So really big fish like shark, marlin, swordfish, because they're eating little fish, they have a higher mercury content, and that can have a major issue for the baby's nervous system development if we're having too high levels of mercury in the blood. If a woman would like to eat a bit of fish during pregnancy, we would say maybe 2 to 3 times a week, and a small amount of something like salmon, tuna, whiting, and then just otherwise have different types of meats and things during that process to avoid any of that happening. So they're the types of things we would really touch on if we need to. Now, one major complication that someone might see a dietitian or should see a dietitian about during pregnancy is gestational diabetes mellitus, or GDM. So this is something that develops in a small percentage, 5 to 10% of pregnancies in Australia. All pregnant women should be tested at 24 to 28 weeks and get a glucose tolerance test to determine if they have this or are at risk. So if they're a little bit of an impaired glucose tolerance and it's only occurred since pregnancy, we think let's keep an eye on this, which of course medical team would be more involved in, but they would send the referral across to us if it is a thing. So the risk factors, this is not limited to these, but these are the sort of ones that pop up and are quite common. So overweight BMI before pregnancy, women above 40 years old, Aboriginal Torres Strait Islanders, but there's quite another extra group of different individuals who also have that high risk as well. And then large birth weight babies with previous pregnancy. So if they had, say, their first child was born over 4.5 kilos, things like that, it does pose an extra risk. And then part of how that's happening is when normally the insulin from our pancreas would come out and take any extra sugar that's in our blood and store that in our muscles and liver, the hormonal changes and production of placenta in pregnancy will have an interference with that. So they're not really doing it to themselves in any way through the diet, but the diet can still help sort that out for them as well. So management, there is diet-controlled diabetes, so they're usually referred to some sort of usually public health, so it might be Women's and Children's, Flinders Med Centre, the RA, and they would see a dietitian usually for an information sort of session where they're all in a bit of a group getting educated. There would be insulin if needed, so that's something that they would look at. For some reason I've written this twice on this slide, but they would work with the doctors and diabetes educators around sorting out what their insulin schedule would look like, when it's needed in the day, and then we can kind of work with that too. So we have a bit of an understanding of it. Of course, we wouldn't change what their insulin is, but we can work with their food and make sure it all ticks off kind of thing. Things we'll focus on, so I'll talk through all this, but we want to evenly spread out carbohydrate foods across the day. So we won't be removing them, we'll just be sort of moderating what that looks like. We'll give education on carb counting, modify a diet based on home blood glucose levels. So we'd usually ask them to provide these in a bit of a diary, and then we'll make adjustments as needed. Talk them through the glycemic index, and then also make sure that the weight gain is appropriate. Again, not too rapid, not too slow, just in the middle, because that can also help with their symptoms. So first of all, just introducing the carbohydrates. Kathleen has touched on these, but it's always good to see them again. So the foods containing carbohydrates, not necessarily good or bad thing, just that they do. So typical everyday foods might be your breads and cereals, pastas, noodles, rice, potatoes, sweet potatoes, milks, yogurts, and fruit. And then your sort of discretionary, sometimes foods that have carbs would be biscuits, cakes, pastries, sugars, honey, chocolate, chips, things like that. Now, foods with no carbs will be things like meat, chicken, fish, tofu, eggs, oils, nuts, avocados, cheese, sugar-free drinks, so your Coke Zeros, any artificial sweetener, and then non-starchy veggies like lettuce, tomato, broccoli will have such little carb that we don't sort of count them in that sort of sense. When we are seeing a woman who has GDM, we are going to be a bit more I guess conservative than we would be with a type 2 diabetic. We need to go straight into things like carbohydrate counting, which we wouldn't necessarily do straight up. With a type 2 diabetic, we might just be slowly easing them into that with some healthy eating, and it should usually sort the blood sugars out over time. But the risk that the high blood sugar has for the baby's development is high, and because the pregnancy is less, like it's a condensed period of time, we would take action a bit sooner and go into this type of stuff. So carbohydrate counting is a little bit of a tedious thing, but once you have it worked out, it's relatively easy enough, and they usually get their heads around it pretty quickly as well, because they've got this motivation to help their baby as well. So we want to aim for a sort of recommendation of 30 to 60 grams carbohydrates per main meal. So breakfast, lunch, and dinner should have this sort of even, medium amount of carbs. What we also might call this, or the way we might teach someone, is thinking one exchange or serve of carbohydrates equals 15 grams of carbohydrates. That's why we would say 2 to 4 servings per main meal of carbs is pretty good usually. Most people have a good response with their blood sugars to that. But we would sort of look at their home blood sugar levels when they test them and adjust it if needed. There will be people who need to eat a little bit less than that, and we'd find that out based on their bloods. But we wouldn't go straight for restricting it, because these foods have a lot of benefits as well. So what an exchange or 15 grams of carbs might look like is a slice of bread or about half a cup of cooked pasta. It might look like 1 medium potato, or it might look like a piece of fruit, so banana or an apple. It could look like a small tub of yogurt or a glass of milk. So just having a look at that, we might say a meal could have 2 carbohydrate exchanges, 2 pieces of bread, sandwich, or it could be, a cup of pasta at dinner, which again gives you 2 exchanges. They both fit in that recommendation. So it's a great place to start. And then snack-wise, we want to go for 0 to 15 grams of carbs per snack, just to give your body a bit of a break between those meals. Doesn't mean to completely avoid, but just not as much as what the meal would have. So a snack could just be a tub of low-fat yogurt or a milky cappuccino with low-fat milk, or it could be a banana, and they would all sort of fit within that as well. Okay, and then it does just mention here, so if we do spread these carbohydrates out across your day, the insulin has a better chance of catching up. So it's not going to be overwhelmed or underwhelmed. It should work pretty nicely, but again, everyone's body is a bit different, so we'd adjust it depending. Okay, we'd also talk to them about glycemic index, or GI. It's a very common sort of term and sometimes misunderstood term. So glycemic index doesn't really refer to how much carbohydrates in anything. It refers to how quickly or how slowly a carbohydrate food turns into sugar and is released into your bloodstream to raise blood sugar levels. So when things are higher GI, using this little graph to explain, things in the stomach are broken down quite quickly, released as glucose into the blood quite quickly, resulting in a bit of a spike, so quite high sugars in a short span of time, and usually a drop. So within 2 hours, you get almost like a low blood sugar. So it can be like a bit of a roller coaster high and then low. When something is lower GI, it's got some sort of complexity to it that slows down the gut. That one's digested and releases sugars over a long 2-hour period incrementally. With lower GI things, we generally recommend them because they give you insulin, basically rest a little bit in between. So low GI meals and snacks is what we would generally recommend. However, there would be times where there's a food that they really like and it's not quite low GI, but we can adjust the meal a little bit to turn it into a low GI product. Things, if we add a bit more protein, so if you're having, say, a white potato that's kind of fitting into this higher GI kind of range, then Kathleen's going to talk a little bit more on these foods. But because it's quite quick to digest, if we added some meat to it, so some protein, and added some fiber by adding some leafy green vegetables, we can actually lower the GI and slow everything down because the gut has a little bit more work to do. So that should help with blood sugar balance as well. And we would usually use practical examples for that. So if we've just got a little picture here. If someone was eating porridge every day, they made maybe some high GI quick oats with water. We could add some milk, which has a bit of protein, and using a higher fiber rolled oat, we can turn their breakfast into a lower GI meal, and they can still have the food they like. It's still relevant to them, but it's much better for their blood sugar levels. So that's the main things we would touch on when it comes to the pregnancy and managing gestational diabetes. So I'll hand you guys over to Kathleen. I'll just stop sharing my screen.
Thanks, Lauren.
No problems. Technology is not my friend.
No. Where are we?
If I can stop that.
That one. What's going on there? Oh, that's better. That was weird.
Perfect.
Yeah. Is that all right?
I think yours is fine now. I just can't see it looking black, but it is definitely your screen.
Oh, it's black, is it?
Yeah, this is your screen, Kathleen.
Oh, yeah. I'm sharing the PowerPoint, but for some reason, hang on, I'll just stop sharing and try again. How about now?
Yep, that's perfect.
That's good. Okay. Hey.
On again.
Oh, it's gone again. Maybe I'll get you to.
Do you want me to click through it for you?
Yeah, maybe let's do that. Yeah, because it's coming up as my PowerPoint, but is it just a black screen?
Someone said in the chat they can see it.
Oh, they can see it? Okay.
Oh, here it is. Yep. And they've just said thank you, David.
Do you want to try try moving the slides? Try changing the slides, please.
Changing it?
Yeah, it's working. All good.
All good?
Yeah.
Oh, okay, thank you.
Yeah, that looks good.
Sorry.
Thanks, Kathleen.
Technology. Okay. So I'm going to move on to childhood and adolescence now. So as Lauren said, we do see children from about 10 years of age. And just to start, I just want to go through a bit about the Australian Dietary Guidelines for Childhood and Adolescents Healthy Eating. So very similar to the adult guidelines, which I'll also go through, we're looking at maintaining a healthy weight and physical activity and nutritious food to meet the children's energy needs. And so we do need a certain amount of and a wide variety of different foods to meet needs and to grow and develop normally. And that includes some physical activity most days of the week. One thing that I've highlighted there in bold is the whole family approach to healthy eating. And I think that this is almost the most important thing with having that whole family approach and the family and the parents setting a good example for their children. And we find that is actually the best way for children and teenagers to manage their weight, because the parents then set a good example. Wide variety of foods, and then of course we're trying to limit, depending on the child, of course we're trying to limit those foods that are higher in saturated fats and added salt, sugars, and of course alcohol, and as best as possible the lunch boxes and meals and snacks should try and reflect the healthy eating guidelines, and trying to limit those discretionary foods and drinks, which I'll go through a bit later. And in terms of weight management, we don't usually recommend that a child loses weight because they're still growing, and that's really important. So we try and usually maintain their weight and let their height catch up with them, and focus our education more on, healthy habits and just healthy eating to begin with. With checking growth in children, so a bit different to how we do it in adults. So we use growth charts. So there's a few different charts that can be used. So we've got the CDC growth charts, the WHO and ANSPED growth charts. So this is just a more sort of systematic way to track height and weight in children. And so if we're looking at overweight or obesity, the BMI for a child who's overweight would be at or above the 85th percentile, and obesity would be at or above the 95th percentile for children of the same age and sex. I am focusing a little bit more on weight management in children, but I think that this is becoming quite common, and it's good to know some practical tips around this. So the Australian Bureau of Statistics in 2022 found that 27.7% of children aged 5 to 17 years were either overweight or obese, which I think is quite common and is increasing. So again, number one thing would be focusing the education and healthy eating education on the parents and the family, and emphasising the importance of setting a good example for the children. And considering where the child comes from, their home. Do they have access to healthy food, and is that actually practical? Acknowledging that obesity is a chronic disease. Previously, it was looked at as, it's almost, putting the fault on the child or the parent. But now obesity is being seen as an actual chronic disease, and that's really important when providing education and to the family and to the parents, and acknowledging that. Eating regularly is always very important, and setting up the day well, having breakfast every day to start the day off with some good nutrition. Trying to eat at the dining table and as a family if possible, and trying to avoid distractions when eating and drinking, because if we're distracted we might then eat quite fast, or we might not, at times might not eat enough for children even. And then trying to offer a wide variety of different foods, even if there are dislikes there. In terms of language around food, trying to avoid labeling foods as good and bad, because this can cause issues later with language around food and negative connotations around food. So more so trying to understand how we can, whilst we are trying to limit the foods, the discretionary foods, we want to look at how we can also fit them into a healthy diet. Generally, we look at full fat dairy until 2 years of age, and again, that weight maintenance rather than weight loss. So this is just a brief look at the pediatric guidelines for obesity of the American Association. So one thing that I do want to focus on here is this empathetic, non-stigmatizing care, and that is probably, again, one of the most important things. And you can see here down the bottom that families won't continue to seek help if they experience stigma. So it's really important to have that empathetic, understanding care, and as well as family-based, and that motivational interviewing as well. Fussy eating is very common in children, and similarly to what I said before, there are a few tips here for managing fussy eating in children. So it's important to know that healthy children won't starve themselves. So if a child is unwell, that might be the case. However, children will eat when they're hungry, and that's usually not at our normal meal times. It might be random times of the day, whereas we're used to eating, regular meals. Trying not to put too much on the plate, because that can actually be quite overwhelming for the child. And so just starting with small amounts, and then they can always have more later. Of course, offering a wide range of foods. Again, even if they express a dislike to certain foods, it's still good to keep offering those foods and that repeated exposure. Also, it's positive to have the same meal for everybody on the table, and everybody eating the same thing. Children often find finger foods easier as well, and being a good role model for the kids, and also eating healthy foods. Avoiding those negative comments around foods that you dislike, because the children might then think they might also take that on, and then they won't want to eat it either. Keeping the meal times relaxed and calm, and avoiding those distractions. Having a routine around the meal times, and avoiding bribing or rewarding with food, because that might also create sort of negative connotations around food, or create issues around sort of regularity, and the types of foods that children prefer as well. For example, they might then prefer sweets, because they might think that that's a reward. This is just some examples of some practical resources that we might share with our patients and with the parents. So in particular, lunch boxes, so just some healthy ideas there that could be offered in the lunchbox. I find that the really, pictorial, practical resources are the most helpful. So looking at healthy dairy, so yogurts, maybe cheese and crackers, for example, hummus and veggie sticks, having a sandwich with a bit of protein in there, lots of salad, bit of fruit, and maybe some popcorn, for example. Or in terms of fruits, maybe some fruit cups, for example, in natural juice. And then in terms of education on portion sizes for the whole family, this portion plate can be quite useful as well, because you've got aiming for about half of the plate with the non-starchy vegetables there. So filling up the plate with that, then we're going for about a quarter of the plate with the protein, and then a quarter of the plate with the carbohydrates. So things like your rice and pasta and potato, for example. There's just some links there. And if anybody would like the slides, just let us know later. But just for a bit more information as well.
Yeah, it would be good if you can share the slide later on, and I can send it to everybody.
Sure.
The certificates. Yeah, thank you.
Yeah, we can definitely do that, and then that way you can follow the links. So with referring for the care of children and for pediatrics, because we don't specialise in children, we recommend seeing a specialist pediatric dietitian, especially for those younger children, below the age of about 10. So there are a few options in Adelaide. So, for example, Women and Children's Hospital. There's a paediatric clinic at Flinders Medical Centre or Adelaide Paediatrics, or chatting to the GP to see where they would recommend, especially for those children who have specific allergies or intolerances, like cow's milk protein allergy, for example, or failure to thrive as a small child or an infant. Fussy eating and selective eating. You might also refer for if there's if there's issues that have medical reasons have been ruled out, overweight or obesity, because even though we don't necessarily focus on weight loss as such for children, we look at those, setting healthy routines and healthy, habits around food. And also, the other end of the spectrum, if children are losing weight or that failure to thrive, for example, you might also refer to a dietitian. Moving on to adulthood now. So you can see quite similar in terms of recommendations for healthy eating, but this is the WHO guidelines for a healthy diet. So we're looking at, again, that varied diet. So most guidelines will have that wide range of different foods and fruits and vegetables, different colours, because that's going to provide different nutrients and a wide variety of vitamins and minerals. So similarly to before, we're obtaining, as I mentioned at the beginning, quite a large portion of energy from carbohydrates, about 30% of energy from fats. So shifting away from those saturated fats that I mentioned earlier and more to those unsaturated, polyunsaturated, monounsaturated fats. So things like your oily fish, avocado, nuts, and away from things like butter and cream, and trying to go for those lean meats, for example. In terms of sugars, so free sugars, so added sugars, generally not so much the natural sugars, but aiming for less than 10% of total energy intake. And then for sodium, we're looking at a maximum of about 2 grams per day, which is equivalent to about a teaspoon, roughly, of sodium or salt. And then fruits and vegetables, so lots of fruits and vegetables, at least 400 grams of fruits and veggies a day, which most of us don't actually get, and that's what I'm going to touch on now. So in terms of obesity in Australia, is becoming much more common, and in 2022, more than 2 in 3 adults had measured a waist circumference that put them at risk of disease, and almost 2/3, about 66% of adults were overweight or obese in 2022. And something that I always find interesting is looking at how many of us are actually meeting the fruit and veggie recommendations. So it says almost there, but it should be probably only 1 in 15 people met the veggie recommendation, and only 4.2% met both the fruit and veggie recommendations, which isn't very much at all. So to give you more of an idea about what we'll do in a normal consultation, for an initial consultation, we're going to go through a case study. So this is based on an adult and based on weight management and also type 2 diabetes as well. So our patient John, he's a 44-year-old male, and he's been referred to us through a GP management plan or a care plan, which we often do see our patients through. So they might get given about 2 or 3 visits with us, and then they might also have a referral for the exercise physiologist as well. And something to mention too is there is a type 2 diabetes referral which can be provided for the exercise physiologist, which often gets forgotten, and that can be really important and really, you know, significant in helping people manage their type 2 diabetes and their weight. So John's medical history, so he has type 2 diabetes, which is diet controlled at the moment, so no medications, and he doesn't regularly check his blood glucose levels at the moment, but he's having his HbA1c checked about every 6 months or so. He also has high cholesterol. His BMI puts his weight in the obese category, and he also has a couple of other medications for, say, for cholesterol and also for reflux, which isn't written there. And so his BMI is 33. So this is a hypothetical patient. However, it's very typical of what we might see in our clinics. In an initial dietetic assessment, to give you an idea about what we would normally go through in our first session with our patients, we do want to look a bit more at medical history, their medications, what are their goals? So are they looking at achieving, you know, a certain amount of weight loss, for example, or it might be something to do with their mobility or their fitness, for example. Social history, so work, home life and who does the cooking and shopping, their current physical activity, weight changes in maybe the last 12 months, so about 9 kilos weight gain over the last 12 months for John. Previous weight loss attempts, so have they tried any other diets in the past, what's worked well for them and what hasn't. Their anthro, so we'll check their weight, height and measurements as well. Biochemistry, which we always find really useful if that gets sent in with their referral, especially if there's other comorbidities such as, for example, type 2 diabetes, chronic kidney disease, anything like that. We find the biochem extremely useful. Usually for our patients, we'll get them to fill in a food diary before they come, about three-day food diary, or we'll go through their diet history with them. And any barriers that our patients perceive, so it might be, for example, stress or time, or maybe portion sizes, for example, are too big. So again, this is quite typical of what we might see in our clinics after doing their first diet history. So we're focusing a bit on carbohydrates here. Because of the type 2 diabetes, we just want to make sure that John's getting the right amount of carbohydrate. So breakfast, it looks like John skips breakfast, unfortunately, but he does have a coffee with some milk, another coffee at morning tea, a couple of sweet biscuits. Lunch can often be a takeaway roll or a rice bowl, or occasionally he'll bring leftovers. Afternoon tea might be nothing, or maybe some chips or a bit of chocolate. And then dinner, because John's quite hungry, he'll end up having quite a large meal at dinner. So a couple of cups worth of rice or potato, for example, about 200, 250 grams of fish or other meat, and then just a little bit of vegetables. And then after dinner, maybe another snack of something a bit sweeter. With drinks, so not a lot of water, but in terms of carbohydrates for juice and Coke, there is a bit of carbohydrates coming in through there. And then protein intake is about 44 to 59 grams a day. So in terms of protein intake, that's looking pretty close for what is standard for an average male. However, if we look at John's actual requirements, so we use John's age, height and weight, and that gives us an estimate of his resting metabolic rate. So that's how many calories he might be burning at rest if he's not doing anything, just laying in bed resting. So that's about 1889 calories a day. So in this context, I'm using calories. With John's activity levels, which isn't a lot at the moment, that would be his steps for the day, about 2,000-3,000 steps. And so altogether, he's using about 2,030 calories a day. In terms of weight loss, so we set a calorie goal for about 0.5 kilo of weight loss per week, and that would bring us to about 1,500 calories per day if we were giving John a bit of a meal plan. And then for protein, if we remember from before, because John's BMI is in that obese category, we'd use that equation of 1 gram per kilo of adjusted ideal body weight per day. So basically with that adjusted ideal body weight, I don't want to get too technical, but if we say we do his BMI at 25 and then we sort of adjust it, so it accounts for the fact that not all weight is going to be metabolically active. So it accounts for the fact that there most likely is more fat mass there. So we're looking at almost 83 grams a day that he actually needs. Some things that we might go through with John in his first session and over his subsequent sessions, we like to focus on sustainable changes. So what are some changes that John is going to be able to make that aren't too difficult and that he knows that he can do, and really get him on board with making some changes, and then we can gradually continue to make those changes over time. So it might just be swapping something out, like swapping out a milk or a bread for something that's a bit higher fiber, for example. So we might look at providing John a 1,500 calorie meal plan so that he can actually see what that looks like, and it gives him a bit more of a guide of how much he actually needs and some meal ideas. Regular meals again, for maintaining his blood glucose levels, and that helps him to keep satisfied throughout the day. Opting for those low GI carbohydrates that Lauren spoke about before, and I will touch on that a little bit more in a minute. Protein with each meal. So that also helps John to feel more satisfied and full throughout the day. It also helps him to maintain his muscle mass, because with this, with our education, we're looking at weight loss. So if John's not getting enough protein, he'll most likely be losing more muscle than he needs to, which we don't want. So we want to maintain as much muscle as we can. Portion control, again, that portion plate. So this is an easy way to sort of look at portions without getting too technical and weighing everything out, for example. So again, the half plate veggies, quarter protein and quarter carbohydrates on the plate. So we're looking at sort of fist size for carbohydrate and then about palm size for protein. And then limiting those higher saturated fat foods, which we'll talk a bit more about, and then those poly and mono unsaturated fats. Label reading we can go through, discretionary foods, so there's sometimes foods, and then we would most likely recommend that John has another blood test in about 6 months to check his blood glucose levels and his cholesterol again, and then come and see us to chat about that. In terms of cholesterol, because John does have high cholesterol, we'd most likely go through this with him. So we are looking at increasing his his HDL, which is the good cholesterol, and to do that we'd look at increasing the healthy fats, so monounsaturated and polyunsaturated fats, so things like your olive oils, avocados, nuts, oily fish like salmon and tuna, chia seeds, flax seeds. We also look at fiber intake, because the fiber helps to absorb the cholesterol before it's absorbed into the body, and helps to lower it that way. So soluble fiber in particular, which is also really good for gut health or for people suffering with constipation, for example. Oats, so rolled oats we'd probably go for because that's a lower GI choice. Psyllium husk, which is what Metamucil is. Legumes, fruits and veggies, and seeds. Plant sterols is something that we might consider. So you might have seen before the heart active milk or the cholesterol lowering wheat bix. If that's something John's interested in, we might look at doing that as well. So the plant sterols are added into certain products, which then gives it a cholesterol lowering property. Lean protein, so really lean protein, cutting off the skin, cutting off the fat before cooking. So your fish, chicken breast, eggs, lean mince, lean steak, and then trying to limit those more processed foods, which tend to be higher in those saturated fats like salami, sausages, bacon, for example. So these are some examples of some simple swaps that we might suggest for John. So usually if you've got a normal wheat bix, we might swap to the cholesterol lowering wheat bix. This is more for cholesterol management. Or we might even do the multigrain wheat bix because multigrain wheat bix is a lower GI option. Instead of his butter, we might go for a proactive or a cholesterol lowering margarine, or even just a plant-based margarine rather than the butter. And in terms of bread, instead of just white bread, we might swap to a much higher fiber bread, or this particular burger one is a cholesterol lowering one with the plant sterols in it, or the beta glucan, which is another type of fiber which helps to lower cholesterol. Or we might just go for a high fiber sort of multigrain, high fiber low GI bread. In terms of type 2 diabetes, there is a few things that we focus on in terms of management through diet more so, and of course if there's medications we take that into account. But weight loss, even a small amount of weight loss can help to reduce those sugars down. So it's got 7 to 10%, but even 5% of weight loss, even a few kilos, can help to better manage those sugar levels. Regular meals again to keep those sugar levels stable throughout the day. And depending on the patient, reducing carbohydrate intake. However, if there are medications, we have to take that into consideration. So insulin or any diabetic medications, because we don't want to lower things too much and then put the patient at risk of low sugars, for example. So we need to make sure they're getting the right amount to suit their medications. And we also, on the other hand, don't want to reduce the carbohydrates too much because we use the carbohydrates for energy and we get a lot of fiber from those sort of foods as well. It is important to know which foods have carbohydrate. So that's what Lauren went through before. And limiting those foods higher in sugar, lollies, chocolate, cakes and biscuits, low GI carbohydrates, limiting alcohol, and then still keeping a wide variety of different foods. Again, these are some carbohydrate foods. I won't go through this too much because Lauren did go through this already, but just to show you, it is quite similar in terms of management for between gestational diabetes and type 2 diabetes. However, as Lauren said, with the gestational diabetes, we get onto it, ASAP in terms of making these changes. But education is quite similar around the carbohydrate foods and those 15-gram carbohydrate serves. Usually for my patients, I'd aim for between 30 to 45 grams of carbohydrate per meal, or 2 to 3 of those carbohydrate serves or exchanges. Glycemic index, again, I won't go through this too much, but to give you a little bit more, examples of those low GI, high GI foods. So obviously the low GI foods, as Lauren said before, help to keep that nice, stable blood glucose levels. You can see with that orange line there in the graph, whereas those high GI foods cause a bit more of a spike, doesn't last very long, comes back down again, then you have that energy crash. But lower GI carbohydrates would be things like your multigrain bread, rolled oats, your multigrain wheat bix, pasta, surprisingly, basmati rice, and most fruits as well as dairy. And then your higher GI foods, things like white bread, the quick oats, the 90-second or the 2-minute oats, jasmine rice, and some fruits like watermelon are on that higher side, and crackers like saladas, for example. Discretionary foods. So we always like to go through this with our patients. So it seems, it seems obvious, but it's still good to go through these things and to give them an idea about, how many calories might be in these different types of foods. So we've got our higher added sugar foods there. So things like fruit juice. Even if the juice is a no added sugar one, that might be a bit better, but it's still quite concentrated in sugar. So when you juice the fruit, you lose all the fiber. So we prefer that, you have the fruit fresh. Higher fat, so bacon, pizzas, chips, cakes and biscuits, and alcohol. And I guess these foods, they do have a place, but they are quite high in calories, and it does add up quite quickly. And just to show you, how many calories might be in one serve of these foods. So it's usually, one serve is considered about 600 kilojoules or 150 calories. So for example, if we look at, say, 2 scoops of ice cream, that's already 150 calories, or 2 to 3 sweet biscuits, for example, half a small bar of chocolate, 25 grams, which is about a row of your typical Cadbury chocolate, or even 200 ml of wine, which isn't a lot, or a beer, for example. Or the one that gets me is the 1/3 of a meat pie or pasty, so it's not a lot, and it adds up quite quickly. And for some patients, which Lauren will touch on a bit more later, that we probably actually need some more of those things, whereas for our patients like John, we're trying to keep those to maybe a couple of times a week. Something else that we might go through with John is a label reading. And now that he knows a bit more about carbohydrates, he can actually keep an eye on that when looking at labels in the shops. But there's a few different things that we can look at. So in terms of fats for cholesterol, in particular, we would focus on the saturated fat. So you can see here, we use the per 100 gram column to compare products. So if we're looking at saturated fat, ideally it would be less than 3 grams of saturated fat per 100 grams. So you can see then saturated fat is 0.3 grams there. So that's within the recommendation. And then you can look at carbohydrates for diabetes. So you have to think about how much you're actually going to be eating. So the serving size here is 30 grams, but you have to consider maybe you would eat 2 serves at once. So then you end up doubling the carbohydrates. And then fiber, so more fiber is good. So looking at more than 3 grams or more per serve. And then sodium, more for blood pressure management, we'd be looking at ideally less than 400 grams per 100 grams, or best would be less than 120 milligrams per 100. So if we were making some suggestions for John, this is what we might be looking at, or a bit of a meal plan for him, so that it's all written out. It's a bit more clear about, what he should be aiming for. So for breakfast, we're trying to bring the carbohydrates down. So we've gone for the, including breakfast every day. So trying to keep those meals more regular, and that helps with the, satiety and feeling more full throughout the day. So maybe even just a bit of fruit to start with if he's not used to having breakfast, or rolled oats porridge, or maybe a couple of those cholesterol-lowering Wheat Bix. So that's about 35 grams of carbs. And then morning tea, maybe a yogurt, so a small tub of high-protein yogurt. Lunch, maybe bringing a wrap from home, so using a wholemeal wrap, or maybe that Bergen bread that we looked at before, or the Helga's 50% lower carb bread. bit of fruit in the afternoon, and dinner looking at reducing those portions, so down to about 1 cup of cooked rice or potato, for example, and then about 100 grams of meat, and then lots of your low starch vegetables and salad, and then maybe a small snack after dinner as well. So you can see the carbohydrates are within what we're recommending of, you know, max of about roughly 45 grams of carbs per meal. And with the drinks, ideally increasing the water, limiting the fruit juice and the Coke to keep those carbohydrates down and those added sugars down. And now the protein intake has gone up a bit closer to what we want them to be, so about 75 to 80 grams a day. And if you're wanting a bit more info, again, we'll send you the slides, but these are just some links to some good places to get some resources from that are practical. So the NEMO we use a lot for patient resources, a bit more about glycemic index there from the Baker Institute, fact sheets from Baker Institute, and healthy eating guidelines from Eat for Health. So I'm going to pass back to Lauren now, who's going to go through a bit more in a case study about older adults now.
Hi.
There we go.
Sorry, I wasn't sure if it got everyone out of me.
I was sort of thinking
Hello.
about it.
I'm not sure what
audio.
happened there.
So
yeah, was that for everyone or just my computer?
I think it was just
I'll
yours.
just share my screen. Okay. It said like just started loading suddenly and you went all frozen, so I just thought I'd get back in. Okay, hopefully my screen sharing and everything works.
Yeah, I'll let you know.
I think it's my internet, to be honest.
Yes,
all
that's
right,
always
let's pull this one up.
Of,
share, and then this one.
Lauren, you can turn off your camera if that helps. Sometimes it increases the bandwidth.
Does it? All right, maybe. Oh, it was off when it happened though. It was when Kathleen was talking. I don't know what was. All right, let me know if anything happens strangely on this one. Why is it
just loading up now?
That one. And does that look okay? Still loading. Sorry about this, guys.
There you go. That looks good, Lauren. Yep, that looks good.
Perfect. Sorry about all the IT stuff going on. So I'll be talking to you guys about the nutrition requirements for older adults, so above 65-year-olds, and then we will touch a little bit on over 50s, in particular women here as well. So we'll talk about that particular point in the life cycle. What we'll touch a bit on here is the little bit of the Australian Guide to Healthy Eating, so just for quality intake, and more so guidelines and recommendations versus exact food groups, but we'll touch on some nutrients in particular. We will look at bone health a lot. That's a massive area when it comes to older adults. Muscle health, meeting protein requirements, looking into a bit of a case study around this. Typical health concerns, chronic illness that might occur in older adults more commonly, and then when to seek dietitian advice. So looking at what time you might make a referral to a dietitian as well. So there are 3 major dietary guidelines from the NHMRC around healthy eating in older adults and maintaining their nutritional status. So the first guideline is to achieve and maintain healthy weight, continue to be physically active, and choose good amounts of nutritious food and drink to meet energy requirements. So again, choosing food from the main food groups, so your breads and cereals, your fruits and vegetables, dairy products, and then your meat-based and vegetarian and vegan alternatives to protein. So that would be your main 5, and then obviously most of times limiting your intake of discretionary foods, but we will touch again on that a little bit because that changes around a little bit too. Staying very physically active, so we work closely with our exercise physiologist at AEP, and they will see quite a lot of older adults in the gym and just help a lot of the time with that side of things. So we don't have to worry about any of that on our end, luckily. And we do talk a lot about, from a weight maintenance perspective, whilst a lot of the time in, say, young, middle-aged adults, we're focusing a lot of the time on weight loss. In older adults, it can be on weight gain as well. Whilst there will be a variety, we'll see a bit of both. That's something we'll touch a lot on this time. So we do know a slightly higher BMI range, I think it's around 23 to 30 kilograms per metre square, is considered healthier for older adults to prevent against frailty and unintentional weight loss. So that's one thing to consider as well, and might be room for a little bit more discretionary treats in there in those particular case group, like those people. The second dietary guideline is around enjoying a wide variety of nutritious foods from the 5 food groups. So it's kind of already talked about, but giving you more practical ideas on how to get those in. We might take a look at someone's everyday eating and think, are you meeting, you know, your typical intake of something like dairy, fruit, whole grains for what they're recommended? And sometimes that can be hard because things like budget, so if someone's on a pension, can interfere with this. We always have to look at their barriers and try to find ways within that to support them during this period, because we do know that their nutrition status will have a direct impact on their health outcomes and quality of life. And then also following food safety and hygiene guidelines. So if someone's losing a little bit of mobility and not able to, say, clean the same way that they used to, or able to see even expiry dates and things on packaging, like there are different things that throughout the lifespan get more difficult. So something that didn't affect them previously actually does, and it puts them at risk of, again, foodborne illnesses. And again, if their immune system is a little bit more compromised from where it was, that can turn into a serious issue versus someone just getting a bout of food poisoning. It can be, you know, grounds for hospitalization and things like that. So it's, again, another one that we touch on with this population group. And the third guideline is, again, a little bit of an iffy one because it's limiting the intake of these discretionary foods. So in general, we would still recommend this for an over 65-year-old. We would also touch a little bit on, with everyone, we do talk about bowel habits and making sure that that's all regular. Constipation is a risk in people over 65 due to the bowel slowing down a little bit. They also might get a reduction in thirst. So we do focus on their hydration, fiber intake, and reducing anything discretionary, mainly for the reason of, if they're eating a lot of discretionary type of foods, is it compromising their capacity to eat enough of the other more important foods that might have a direct impact on either symptoms or health outcomes, quality of life in the future? So they're the 3 main guidelines there. Now, nutrition for older adults. So things I'll touch on again. Can't go into all of them, but they're things that might be quite relevant. So the nutrients of interest are kilojoules, calories, energy in general. So making sure they're either, you know, getting enough to maintain their weight or potentially put on. Protein's a big one to reduce risk of frailty, sarcopenia. Calcium for bone health and teeth health. And then main conditions that we might see in someone above 65, more specifically, so osteopenia and osteoporosis, sarcopenia, osteoarthritis, Alzheimer's dementia is one that's come up a little bit, and menopause we've popped in there, and mainly because we might see someone postmenopausal who's suddenly got a very high cholesterol level. It can be linked with osteoporosis, or they're getting a little bit of visceral fat gain that they're concerned about. So whilst it's not quite older adults, more middle-aged, it still sort of fits within this period, like patient group, I guess. So this is a question, and we're going to use the poll, but because my technology on this computer is not the best, I might get Kathleen to have a look at the results, if that's okay. So the question that we're asking on the poll is, how many milligrams of calcium do you think that a woman aged 50 and above would need every day? So 3 options:
Oh, I think something might have happened to Lauren's internet. I've got one guess there, 2,000. We might just wait for Lauren's internet. Oh, she might be back now.
Oh, did I drop out again? I can't even tell.
Yeah. Silly internet.
Do you want
I've
me
got a
to
couple of
launch?
guesses. So your camera's gone dark now, Lauren, for some reason. And the PowerPoint's not sharing.
The PowerPoint? Okay.
Yeah.
I might try
there you go. I think you're back now. Although
back now.
it's looking a bit slow. Your camera's back, but it's
All right,
just a bit slow.
I'll turn off my camera, and like what Monica was saying, it might help with the
Yeah,
bandwidth.
we'll do that. Yeah.
Okay.
And then if you want to reshare your screen with us again.
Yep.
And do you want me to launch the poll now?
Yes. Yep.
Thank you.
That would be great.
Did that one?
Cool.
You guys able to see my screen now?
Yep, we can see that, Lauren.
Perfect.
So we've got a couple of. Can you see that, Lauren, the poll?
All right, I might log out here and just look at the poll probably. Oh, cool. All right, we can all have a look at that.
Got a few guesses.
So I think the middle one must have meant to be the 1,200, and that one's winning. So the results, I'm thinking majority of people have probably voted. Oh no, still some coming through.
Still a couple going.
Yep.
I'll close it at
Well, this is exciting.
Yeah, it looks like around that middle one, the 1,500, or the 1,200, I think.
Yeah, meant to be the 12. Yeah, I don't know what happened with that one, but I'll hopefully my screen is sharing. I'll bring this one back up. You guys are able to see that?
Yep.
Perfect. All right. So the answer, everyone, pretty much majority was correct. So the 1,200 milligrams a day is the main recommendation. Those who said the 2,000, they were kind of correct as well. It is the upper limit. When we are, like in particular, females aged 51 to 70 and then above, and then males 71 and above need the 1,200 milligrams a day. They have a much higher risk of brittle bones, osteopenia, osteoporosis, and require quite a significant amount of calcium a day. The 1,200 milligrams is roughly equivalent to your 4 serves of, standard serves of dairy a day. There are other ways to get it in as well, which we'll have a discussion about, but it is quite a significant number, and it's a bit of a climb as well, just to get that extra serve sometimes with people. So that's something we will work on with the clients during our consults. So bone health and calcium is a focus point as well. So it's used in the prevention and treatment of osteoporosis, osteopenia, falls and fractures. We focus a lot with our clients if they present with these type of issues on meeting calcium and vitamin D requirements through food and supplements when needed, adjusting dietary intake based on their intolerance, likes and dislikes. So you will often come across clients that might be a little bit challenging in the sense they dislike or can't tolerate most milk products or any sort of dairy. So we will try to work through that, and that's where supplementation is also useful. Bone health and calcium, again, what is these servings looking like? So a cup of milk is a serve of dairy, 2 slices of cheese is a serve, a third of a cup of yogurt, or 1 cup of a dairy-free alternative, so soy milk, And you can also use other type of things to get a fair bit of calcium as well. So there's the John West Protein Plus tuna as well, or the So Good high protein almond milk. They both have 1 to 2 serves of calcium in them. And it does mention down here the serves per day based on male and female and the ages and how that sort of climbs. So you notice that women earlier in their life, from their 50s onwards, do take quite a jump from 2.5 serves to 4, which will happen to men age 70 and above. So again, looking into how we might do this with a client that we see in our clinics, we would sort of, if it's a typical kind of meal plan, in a typical sort of patient who's maybe age 65 and above, what would they have? And we're trying to go for a few things that have some dairy and also don't. So we want them to get the 1,200 to 2,000 milligrams of calcium a day. So the 1,200 is enough to prevent the deficiency and support the bone maintenance, whereas the 2,000 is the upper limit. We wouldn't want it more than that. We do know that calcium is stored majority, so upwards of 95% in our bones and teeth. We do have a small percent that's in our blood, and that's going to keep our heart pumping and moving. So if we are low, so beyond the 1,200, below that, the blood will likely take from the bones to keep the heart going. It's the most important thing. And then later on, that's where you'll see worsened effects, so bone density declining. And then the 2,000, if we're getting more than that, that can affect the heart also in a problematic way. So we try to keep it between there, and kind of we're able to count that up with the client and make sure their meal plan works with that. So an example that I've done here is breakfast. So 2 slices of wholemeal bread with a couple of slices of low-fat cheese and tomato, which provides the 320 milligrams of calcium. Morning tea, so a low-fat yogurt containing 170 milligrams of calcium. Lunch, we've used the John West protein-rich tuna, which provides 800 milligrams of calcium. So its majority is coming from this tuna. Obviously, you wouldn't have it every day, but it's a great way to quickly get a bit of that in. The afternoon tea, handful of almonds, which has some calcium, not really worth counting, but it does have some, and a banana. And then dinner, they're having some basmati rice with stir-fry veggies, 150 grams lean chicken. That's just something healthy, protein rich that they're having. And majority of their calcium has come earlier in the day, and they are meeting that lower end of their calcium requirements of 1,290 milligrams a day. So you can see how it is. You have to be quite intentional when it comes to calcium, and a lot of people are usually quite a bit under that. People generally that we see may only get a serve a day, if that. So it's just an important thing to for us to have a look at. So supplementation, something we'll use if we need to. Sometimes a patient might present and they're already taking a supplement, so the GP set them up with something. It might be something like Ostalin or Caltrate. They might be taking just a vitamin D to help with the absorption into the bones. We use a food-first approach, so we may think, are you going to be upwards of that 2,000 a day with the supplement because you're already actually meeting it through your food? And then we might suggest discussing with the GP if they can just get it through their food. It's just the best way. You get the other benefits with the dairy products, for example, or the tuna in terms of protein. However, if they're really unable to get it through a lot of food things and all of the options they don't love, or they're just very inconsistent with it, you would probably do 1 to 2 a day of your Caltrate or Ostalin, which would give you between that 600 to 1,200 milligrams of calcium from these products. But yeah, we always suggest, we wouldn't necessarily just say, just take this. We'd talk and say, have a discussion with your GP and make sure it doesn't interfere with anything else before you commence this supplement. With vitamin D, mentioning it is important for the absorption of calcium from the blood into the bones and teeth for storage. We want to screen for optimal levels, so get blood tests done with the GP, and then supplement where appropriate. If we're noticing there's a bit of a decline, so someone's at their really low end of what's normal range, or they're actually low, we of course need it, because even if you're great with your calcium intake, if your vitamin D is low, you're not going to get all the benefit you could get. And with these two supplementations, we make sure that people have them with food. So the type of calcium in Ostalin and Caltrate is calcium carbonate, and it needs food and fat-soluble products for absorption, and so does vitamin D. So that we always encourage that as well. Okay. Nutrition requirements, again, for older adults. So what are our main focuses? Again, after bone health, we look into muscle mass and strength, so preventing things like sarcopenia. We do know there's, with age, a decrease in skeletal muscle mass and strength due to reduced muscle tissue production as we age and progress through life. Maintaining healthy weight is also part of that. So we want to sort of retain muscle mass, weight mass, so that we're not seeing lots of losses. Weight loss when you are older is different from when you're younger, and a lot of it does come from muscle. So we actually don't encourage heaps of weight loss in certain populations. Unintentional weight loss and frailty is a big concern in older adults, and something that I think a lot of GPs are starting to screen for a lot now. There's certainly a lot of over 75 health screening tests and care plans that we see a lot of patients on. This is something, again, occurring for many reasons. Like there's a loss of thirst, there's sometimes a bit of a loss of appetite that naturally happens over life. Certain changing circumstances, so more emotional things or routine based, like if someone's retired, no longer as active as they were. There are things like death of spouses. So when someone's cooking for one, it's a bit harder and less motivating. Memory and mobility issues. So reminding, like even being reminded to eat without the routine of things like a work schedule or kids around for dinner, it can be tricky to have that routine, and people do forget to eat. It's quite common. And then mobility, so wanting to eat, having a desire, but no longer having, say, the dexterity to cut up things, like weakness in the hands, even standing for long periods, struggling with that, carrying groceries. All of these things can lead to this unintentional weight loss and frailty, and we do see it in a lot of different clients that we see. This can result, again, in a higher risk of malnutrition and sarcopenia, and it's, again, relatively common, unfortunately. This is a case study. So this client I've named Mary. She's a hypothetical client, but she's kind of based on a few different clients that I have seen who have had very similar sort of presentations. So Mary's 85-year-old female. She was referred through a home care package. So she potentially could have, if she was coming to our clinic, she might be seeing a physiotherapist because she has had a hip fracture following a fall. So she was hospitalized for that, and she would be doing a little bit of ongoing rehab. And then she's also referred to see a dietitian because she's had an unintentional weight loss of 10 kilos, which for her, she's quite a little lady, that was 20% total body weight loss, quite significant. And most of that would likely be muscle loss as well, unfortunately. She lives alone, she is widowed, she is relatively independent with her ADLs, however, needs maybe a bit more assistance now. Medical history is osteoarthritis and osteoporosis, so very common conditions. Some of her objective measures, so she's 160 centimetres, 45 kilos, and has a BMI now of 17.6 kilograms per metre square. So she is considered underweight for her age. Our initial dietetics assessment for her is looking at her medical history. So we've had a look, osteoarthritis and osteoporosis are her main conditions. Medications that she might be taking, so anything that might have an impact on her weight or eating or drug nutrient interaction that we'd want to be aware of. Her health goals, so where would she like to be with her weight? Does she want to get back to where she is? What's her motivator for that? So is it about getting, again, feeling healthier? Is it about preventing sort of any other, decline? What is her main motivators to help, push her along and get her back to where she needs to be? Social history. So again, learning a little bit more about her and what's practical. Do we need to put in some things in place, like for example, Meals on Wheels, other services like that to help her meet her intake? Is it to do with her mobility, or is it to do with her budget? What are those sort of parameters? If she's on a home care package, things like Meals on Wheels are possible through there. So we'll definitely see if we can do something like that and advocate for that. Physical activity, again, is she doing anything probably with the physio most likely that's going to affect her intake or burn a lot of calories that we need to be aware of? Weight history, so I've mentioned here she's had this weight loss and it's all in 6 months, pretty quick. Any supports in place, changed eating habits to gained weight? So has she, before seeing us, been doing anything that's been helping, not helping, and yeah, what's worked in the past? So her anthropometry, again, I've talked about her height, weight, and BMI. Biochemistry, so something I'll touch on is very clinical, not always seen in private practice, but important. So refeeding after a long period of not eating quite enough. So if someone's low phosphate, potassium, magnesium, or sodium, so electrolyte disbalances, that can occur from undereating and then eating again. So I'll go into detail a bit more about what that is. That's an important one with these underweight clients. And diet history, we want a full diet history of what they normally eat, which is usually helpful, or they can do a 3-day food diary, which they usually do with their intake. It just helps us get an idea of what's been had, what they're actually getting, and versus what they need. Likes and dislikes, so things that might affect what we recommend for them, and barriers and nutrition impact symptoms. So what is the degree of their loss of appetite? Do they get early satiety, so getting full really quickly? Is it a disinterest in food? What sort of things do we need to break through, and how can we make their food a little bit more appealing to encourage this weight regain? So we would first work out her estimated energy and protein requirements. We know with Mary, she is underweight, she's lost significant weight, and her hospitalisation has led to her not being able to meet her new energy and protein requirements. She's always been a slim person, but she, because of this injury, kind of has a little bit of increased energy and protein requirements. She's never been a big eater, but all of this happening has made her lose her appetite even further. So this combination of things has meant she needs energy and protein requirements for repletion. So it's based on roughly energy about 30 to 35 calories per kilogram body weight daily, and protein 1.2 to 1.5 grams protein per kilogram body weight daily. So that ends up for her, again, she's needing about 1,350 to 1,580 calories a day, and between 54 to 68 grams of protein a day. With this case study, because we need to be mindful, I won't go too much into energy, but because her loss is mostly muscle, and that's the most highest risk of things like sarcopenia, I will look at protein in a bit more detail with this case study. So looking at Mary's diet history, I've counted up how much protein I think she's having. Again, this is a made up kind of person, but it's kind of based on people we have seen. So she starts her day with 2 Weet-Bix, half a cup of low fat milk, getting about 6 grams of protein there. Not a lot, but not too bad. Pretty common. Morning tea, she doesn't really eat anything. She's not very hungry. She's just getting coffee, about half a cup of light milk again, 4 grams of protein. Lunch, she can only manage a small piece of toast. She's having some smashed avocado on top of it, which gives about 2 grams of protein for this particular meal. Afternoon tea, another coffee with a banana, 4 grams of protein. Dinner, something little again. She doesn't have the desire, and it's something nice and easy. A cup of chicken soup, slice of bread and butter, 10 grams of protein, all that. Supper, again, she's having a cup of tea, so 4 grams of protein. Majority of her protein, weirdly, is coming from her tea and coffee. That's where she's getting majority of things from, and that's just from the milk. So her actual intake of protein is very, very minimal. Some people get that amount in a meal. She's getting about 30 grams a day, which is meeting only 44 to 55% of her estimated protein requirements, or EPR. That puts her at risk of, again, muscle loss, sarcopenia. Okay. Next thing that we want to look at with her is flagging for refeeding risk. in Mary, because of this parameter, so when someone does go from very little eating, losing a lot of weight, suddenly eating more, which is what we're going to recommend for her, there's a slight risk in certain patients of electrolyte disbalance, which is, it's a very medical thing, but a dietitian is usually a one person to see it because we're able to assess that intake, and we do flag it with the medical team if we think it's going to be a risk. She's very borderline, so her weight loss being over 20% does qualify her as a refeeding risk. Without any biochemistry, it's hard to know if this is a thing, and it's not that common, but it is a little bit of risk, so we do have a look at it. And her BMI is under 18.5. So she does tick 2 of the boxes for refeeding risk, and I would flag that with her and talk about what that might mean, and also just probably write to the GP or call them, depending if Mary's going to see them soon or not, to look at her bloods. So have a look at what her electrolytes are doing, have a look at what her phosphate, thiamine, magnesium, and potassium, that is an electrolyte. Have a look at what they're all doing and make sure that they're not going low or sort of dysregulated when we implement our nutrition plan of giving her a lot more food. I would be letting her know about starting just a general multivitamin, which can help protect against this while you're in that process, and also making up for any mineral deficiencies or vitamin deficiencies she may have. And I would put it through to the doctor first. I wouldn't necessarily just recommend it myself, but I would say to consider supplementing a bit of phosphate and thiamine, and put some suggestions down that they can make sure is clinically indicated as well. So that's one of the more risky things that can happen with these clients. Now, my diagnosis and treatment plan. So I touched on this a little bit, but assessment, we make a full diagnosis. So malnutrition risk is number 1, related to her inadequate energy and protein intake, secondary to her severe loss of appetite following her hospitalization for her fall. It's evidenced by her low BMI, her high percentage of body weight loss within a short 6-month period, and a diet history that only meets 44 to 55% of her EPR. She is a refeeding risk because of the high body weight loss being more than 20% within 6 months as well. She would benefit from a high protein, high energy diet with oral nutrition support supplements to promote her weight and muscle repletion as well. So the plan that I would put in place with her is I'd give Mary education regarding high energy, high protein diet, aiding weight gain, give her education on the importance of 6 small meals across the day versus 3 if she would like something like that. But we'd probably have to work with her cups of tea and coffee, I'm thinking, as well. She doesn't necessarily snack a lot. We would provide education on strategies to fortify meals and beverages to increase energy and protein content without increasing the volume of the meal when her appetite's poor. So I will show you some practical examples with that. And then again, contacting the GP about the refeeding risk, so we can do a bit of a plan to make sure that risk is reduced. Now, food fortification, this is on that high energy, high protein diet. So it's essentially basically giving someone enough energy and protein to replete what was lost and replenish what they need without giving them a high volume of food. So we're making every mouthful count, basically. If someone only is able to get through half their meal, but half their meal provides pretty much what a full meal typically would look like, we can make that work. And then they can actually regain this stuff. So we work with them to find foods within their diet that I think they're not providing enough protein or energy. How do we increase this? And we put little different products in there to make sure that it hits those targets. And it's used in the context of low appetites, nausea, or increased energy and protein requirements. If someone has had a fall or had some sort of condition, like cancer, for example, where they need a little bit extra. This is practically showing you a few pictorials. So the process of fortifying a product, if we focus on Mary's cups of coffee and tea, like I said, she's having a fair few a day and they're not really giving her much. It's about 45 calories each and 4 grams of protein. So very minimal. She's only getting like 12 or something a day grams of protein from them. It's quite low. If we use a couple products from the supermarket, there's a milk called Complete Dairy High Protein Milk. So normal full glass of milk has 8 grams of protein. This has 15, so we're doubling easily. So even if she's getting half a glass, she's getting the amount that a full glass of normal milk gives her. We're also going to add some skim milk powder. Again, won't add actually much volume. It won't taste heaps different, and it's mixed into the normal milk, but it provides quite a lot of protein. So with this, we're getting her from 45 calories to 130 calories, and we're going from 4 grams of protein to 12. So she's getting 3 times more energy and protein from that switch. If we focus on her lunch as well as the second thing we change, her 1 slice of toast with avocado gives you about 297 calories and 3 grams of protein, 2 to 3. If we use a high protein bread, so Helga's has one, put some cottage cheese through the avocado, which you won't notice too much, but is in there hidden. We go up to 340 calories and 11.5 grams of protein. So almost 4 times more protein in the exactly the same sized meal with hardly any differences. So they're the type of practical things we do, and we can make it work with lots of different clients with lots of different tastes. Looking at how this has worked for Mary. So again, we would look at, usually in clinic, we'd look at energy too, but we're really honing in on protein here. By fortifying her tea and coffees, she's having about 2 to 3 a day. We're giving her 36 grams extra protein. So if we take away what she was getting and add what she would now get, she's increasing by quite a lot. Her lunch fortification, so the changes in the toast, provides her an extra 11.5 grams of protein instead. So her total across the day goes from about 30 to about 65.5 grams, which is meeting her requirements. She's kind of right in the middle of what she needs to be now. So that should help with the muscle repletion straight up. What I would do as well, I did mention briefly oral nutrition support supplements. I'll just touch on these. They might look quite familiar. In practice, we use pretty much all of them, depending on what the client likes. There's things like Ensure Compact. I like using them because they're really little. They're 150 mils, I think, and you can get them down in probably 2-3 mouthfuls. But they're the same protein as eating a small sandwich with meat, so they're really helpful. That might be something I'd recommend for Mary once a day, twice a day, just to get a little bit more in if she can't get it through a meal. Forta juice. Oh no, sorry, we've got Resource Fruit Beverage. That's again more of a juice-based one if people don't love the dairy products or it doesn't sit well for them. They're quite high energy, fair bit of protein. And then the powdered ones, which are more affordable. So Ensure and Sustagen are sort of fan favourites, and they would just be mixed up. So if people have the dexterity and able to make that up at home, it's a great way to make sure it fits within the budget as well. So they would be a recommendation too. We'd try again, food first, and then see if the support supplements are required as well. So that would be my main way to manage this type of client. This is a list I'd give them. So I'd give them a bit of information and a lot more detail on that high energy, high protein diet, some recipe ideas, probably talk to them about starting something like a Sustagen a couple of times daily if needed, or using it in place of a meal if she can't eat. Talk to the GP about refeeding, review in about 2-3 weeks just to see how she's tracking along. With diet, we don't see them super regular, but I could see her more regular if she's really at risk. So we can sort of make that judgment call as well. And that would be the main management. Now, this is just touching on when to refer to a dietitian. So things we can help with, summarising: new diagnosis of a lifestyle disease, so things like metabolic conditions, type 2 diabetes, kidney disease, hypercholesterolemia and hypertension. Weight management, so again, unintentional weight loss like Mary, or someone who's overweight and obese wanting to lose weight. Poorly managed pre-existing conditions, so someone with type 2 diabetes for 10 years, but it's suddenly gone bad. They were very controlled for a long time, but they need extra help now. patients with low health and nutrition literacy, where they might have a care plan and want to learn a little bit more to prevent health conditions in the future. Vitamin and mineral deficiencies. Iron deficiency is a very common one that we see. GI disorders is something we haven't talked about in depth, but we see a lot of. So inflammatory bowel disease, so ulcerative colitis and Crohn's, diverticulitis, celiac and irritable bowel syndrome, which is a common, we do see quite a lot of that. And I think we've mentioned that twice, low health and nutrition literacy, yeah. So they would all be things, and it's kind of not limited necessarily to that either, but it's quite a wide range of different things we'd look at. Referral pathways for dietitians. So Kathleen's mentioned these already, but that's just showing you them again. Private NDIS, EPCs and TCAs, home care and Commonwealth care packages, and also eating disorders care plan through Medicare. So that's a newer sort of one as well. And then Kathleen talked about the type 2 diabetic plan, where you can see a dietitian as well. Oh, there's just some references.